Good morning, everyone. Welcome to Pediatric Grand Rounds. Welcome to our applicants. Hope you're enjoying your homemade breakfast that Hopkins and every place else doesn't have. All right, today's presenter is Dr. Amy Kryder. Dr. Kryder trained at University of Maryland for her medical school and her pediatric training prior to joining Carilion in 2009. She has always been an active, very active participant in all educational activities here at Carilion, and currently serves as the medical director of the school nursing program, as well as the section chief of the Botetourt Pediatric Office. Please welcome Dr. Amy Kryder.
Hi, good morning, folks. I felt really confident in giving this talk until I saw 8 applicants walk in. And I thought, oh boy, I forgot that it was interview season. So now the stakes have risen for me. Also, Lori Dudley is in the back of the room, which makes me really nervous about talking about anything with ADHD besides medications. So I wanted to start a little bit with why did I call this ADHD and the kitchen sink? The goal when I first started this presentation, or I decided to do it, was to present an overview of evidence-based, complementary, and integrative medicine, hopefully finding something that I could generalize and use in my own primary care practice, in addition to what I was usually doing. But I was thwarted by a lack of evidence. I also found that I just encountered a jumbled up mess of seemingly unrelated topics. And so I felt like I had pots, pans, wine glasses, my rolling pin, and anything else in the sink. And I couldn't bring it all together in one common framework. So I am not going to talk about controversies related to how we diagnose ADHD, why the incidence is going up, or in the U.S. Worldwide incidence is cited to be 5.5%. In the U.S., we're 11%. I started to think, is this just a first world problem, that when you're worried about food and you're worried about shelter, ADHD kind of goes down the line of your priorities. But I couldn't resist this funny. This is a study that was done about a year ago, and maybe 2 to 3 months ago, I started to see some popular press coverage of it, and it was done by an economist, which is, I think, the important part. And it says researchers were shocked to find out that August babies are more likely to be diagnosed with ADHD. Does anyone know the school cutoff date, the residents maybe? Don.
You know, just on the news this morning, they didn't reference that, but they referenced that children who start earlier than the cutoff have a 30% chance, a greater chance of being diagnosed.
Yes. So the school cutoff, at least in Virginia, is September 1st, August 31st. So these August babies are the youngest. Does this shock any pediatrician? 18 kids. Yeah. So conflicts of interest, I have no pertinent conflicts of interest, with the exception of I live with 3 people with ADHD. My husband, who was never diagnosed, struggled in school, and is clearly hyperactive. He cannot sit still, acts constantly, still as a 50-year-old, and has 0 sense of time. I have a 14-year-old who used to run laps in my kitchen when she was spelling her spelling words because she had got still all day in school and had to get the wiggles out. And I have a daughter who was diagnosed a little bit older because she was so bright. And she's inattentive. And she could miss half the material in early elementary school and get by just fine. So objectives of the talk, I'd like to identify one non-pharmacologic approach that is supported by evidence. I'd like to identify one nutritional myth related to ADHD, and talk a little bit about the rate of conventional medication failure, which is significant in this disease process and discuss the intersection of sleep and ADHD. This talk is going to focus on what I found most interesting and generalizable to my personal practice, which is a little bit about nutrition to help answer family questions, and a little bit about sleep, actually a fair amount about sleep. So the structure of the talk, we're going to survey complementary and integrative medicine interventions, but I want audience participation there, especially anybody in a primary care setting. We're going to conduct a very high-level overview of some complementary or integrative interventions. There's simply too many to put on, multiple slides. And we're going to focus on diet, cognitive behavioral therapy, and sleep. And then we're going to review two well-done studies, in my opinion, about sleep and ADHD. Okay, I had to list the DSM criteria of ADHD, right? So this is actually shortened. I think every version of the DSM just comes up with a longer and more verbose criteria for any disease process. So since that violates all slide-making rules, here is a summary. Kids with ADHD are impulsive, they're inattentive, they're often emotionally labile, highly sensitive, and we know that they are hyperactive. The DSM-5 changed it from symptoms have to exist before age 7 to symptoms have to exist before age 12. They have to go on for more than 6 months. And most importantly in psychiatric literature, they have to cause impairment. So you can be hyperactive for a little while, but if it doesn't impair your function, you're just fine. What do inattentive kids look like? They look like they're ignoring you. They're missing information in school, and it eventually will lead to poor performance because they're missing the information. It gives them decreased self-confidence, decreased self-worth, because they've got a decreased sense of efficacy. They know they're underperforming. The impulsiveness makes them hit, makes them act out as young kids, makes them act explosively sometimes or seemingly. They can't keep their hands to themselves. The kids, as they get older, don't want to play with them because they're annoying to them. They're emotionally labile. A lot of times when they get home from school, they want to be good. So they have kept everything bottled up just as long as they can. And then they get home and they explode. And I do notice a lot of sensory issues in kids with ADHD, and that's reported. They're sensitive to noise, to touch. They like weighted blankets. They like hard hugs. And they need decompression from all of this sensory input. But unfortunately, the young ones and the immature ones don't know that they need this decompression. They can't choose to act on that. So as an introvert, I can choose to be alone and recharge my batteries. A 7-year-old with ADHD, he can't make that choice, even if he realizes it, because he's got to sit at the kitchen table for dinner. That's what his parents require. So some statistics. I talked earlier, the rate in the U.S. is 11% reported to be. That seems so high to me. I really don't think I've got 11% of my primary care panel diagnosed with ADHD. Worldwide rate is 5.5%. At least a third have existing comorbidities that I'm going to talk about. 70% at some point end up on medication, but more than 30% with medication and psychotherapy continue to be symptomatic. And it's got a persistence into adulthood of approximately a half. So what are comorbidities? Depression, anxiety, learning disorders, sleep disorders, oppositional defiant disorder and conduct disorder, autism spectrum, and tics. So what is complementary and integrative medicine? For those of you who can't read the little caption of the woman with plants growing out of her head, It says, I think this is a side effect of those herbal eye drops you've been using. I think that's probably more alternative medicine, and I'll define that in a minute. I forgot the animation was there. The complementary and integrative medicine. Integrative medicine is conventional medical treatment in addition to evidence-based complementary treatment, and then an environmental focus. So the environment, maybe the family, it may be their physical environment, such as exposures that they have, what their housing situation is like. Do they live in the city? Do they live in the suburbs or in a rural environment? Do they have heat? Do they have a high-stress family interaction? Or do they have a family who's organized and can assist them in being organized? What's their nutrition like? What is the psychosocial state of the child? How's school going? Do they have friends? So complementary medicine involves evidence-based things. Not all of these are evidence-based for ADHD. I'm going to talk about some individual interventions. But in general, it may include nutrition, dietary supplements and herbs, mind-body therapies, probiotics, acupuncture. The list goes on. Alternative medicine is now defined as non-evidence-based medicine that's used in lieu of conventional treatment. So this is where people have to talk. I wanted to hear a little bit about what complementary or integrative or alternative things folks have encountered in their practice, because I've encountered a lot, and that's why I started this talk in the first place. Anyone been asked questions? Yes.
Low sugar, gluten-free.
Yep. I'm going to talk about that one, release the sugar. Yeah. Decreased dye, especially red. Decreased sugar. Decreased gluten. Anything else?
Fish oil supplementation.
Food allergy. We'll cover that. Fish oil, we'll cover. Anything else? Okay, so there's a medical food out there right now called Viarin. I've been asked to prescribe that. Medical foods are produced by a pharmacy. They're FDA regulated. They don't require a prescription, but they require evidence that a doctor is involved. And this is a proprietary omega-3 preparation. And so I have to write a prescription to prove to that company that I'm involved. There is a chiropractor in our area who calls himself a functional neurologist. I'm not quite sure what he is doing for ADHD and autism, but I get lots of questions about him. Lori knows who he is. I get questions about herbal supplements. I had a kid come in a couple years ago who was obviously having stimulant side effects. And I looked up this herbal supplement. After a lot of digging, it contained ephedrine. So it probably did work a little bit, but it also caused significant side effects. So these, plus many others, I have been asked about personally in my practice. And it's so challenging as a primary care pediatrician when you're asked these questions. We have a large breadth of knowledge. We don't necessarily have a large depth of knowledge in any given area because we can't afford to. There's just so much breadth that we have to know. And so you're asked these questions and you're just kind of left fumbling. I want to help you, but I don't quite know how. So CAM, or complementary and alternative medicine, I'm going to flip between those two terms because integrative medicine is more newly defined than complementary and alternative. It's reported to be used in as many as 50% of kids with ADHD. And I think that's probably true if I look at sleep interventions, if I look at interventions that aren't just herbs or dietary supplements like we consider. They just don't talk about it with us. So this is my overview of medications. We're not going to talk about them a lot, but I'm going to cover them because I want to address why I believe families are using complementary and alternative medicine. And a lot of that is that 30% failure rate. So many families are drug hesitant. Why? It can cost them a lot. I find that long-acting preparations of Ritalin, of amphetamines are unpredictably covered and often poorly covered by some of the insurance products out there. The plan year will change, and they will suddenly tell me that they're no longer covering this child's Vyvanse, that I have to show that they have treatment failure of 3 other drugs first or 2 other drugs first. And maybe Vyvanse was the first thing I put them on, and it worked great. And why does the family want to change that? They don't. But suddenly they're faced with $150 a month to cover that kid's drug that they're currently on. They're a hassle. In my office, we'll give you 3 months of prescription or for stimulants, but you have to come in and pick them up, and you have to do that between 8 and 5. We will sometimes mail them, but we don't like to mail them. 1, we have to do it by certified mail, but 2, if you lose them and I mailed them and you call me and say it never got there, do I believe you? You know, these are drugs that can be abused, that can be sold. If they want to be dosed at school or give a second dose of medication at school, they have to drop them off to the school. The school nurse has to count them. They have to take an order to the school nurse for it to be administered. These are all a lot of steps for families whose parents often have ADHD too, because it's genetic. Some kids don't want to go to the school nurse. It's stigmatizing. They don't want their friends to know. Families have an idea that medications are just a crutch, which I say, yes, they are. And there's a good reason that we're going to prop your kid up until they are old enough to use and develop all of the other coping skills. And then there's always the family lore of Uncle Somebody who was made into a zombie by Ritalin. I hear that all the time. And I guess my idea is, 1, that doctor didn't know what they were doing, or 2, you had 1 tool and a square hole, and you hammered that round tool into that square hole because all you had is 1 tool. Why else are they drug hesitant? They know they're controlled substances. I tell them that when I prescribe it. So they're worried that their kid's going to become an addict. They may have a bad personal experience in that kid with medication, or they may have a bad family experience. And finally, there's a lack of efficacy and a lack of side effects, and side effects. And often we have to change medication. I tell families I get it right about 80% of the time, the first time. But they may be back in my office time after time for a few months until we get it right. I don't need to read a long list of drug side effects for you guys. A couple things I wanted to highlight. I definitely have seen kids get very emotionally labile with stimulants, especially as they wear off. And that is really, really concerning to parents. There are drug management strategies that you can do. You can look them up. They're even in up-to-date if that happens. But it does happen, and it's something you're going to have to encounter and deal with. The other thing is, I never believed hallucinations until about 4 months ago. I had a 1st or 2nd grader, I don't remember, it's a little boy, who came into my office at the first patient visit, and he could not sit still. He looked like there were ants crawling on him. And it was in the morning, He was improving, but 24 hours before, he had been given a first dose of Vyvanse 40. Vyvanse starts at 10 milligram dosing that was prescribed by another physician in an outside practice, and he had never been on stimulants before. So this little first or second grader got a really high dose of Vyvanse. He was hallucinating in school that day. He hadn't slept for 24 hours and absolutely still couldn't sit still in my office. So I really agreed that kid needed medication. After I was talking to Mom, she brought in all of the school documentation that they had done. And we talked through the side effects and started him on something else in about 48 hours after all of that had worn off. So what are some complementary and alternative medicine overview? I had to add PCIT up here because we do it. It does work and help. I'm not sure that there's evidence that it specifically helps in ADHD. If you look at bigger studies, they're hard to find. But I enjoy having it as a resource because a lot of times there are parenting issues too. Sleep, food, all of those we've listed up here. If we look at diet, Dr. J. Joe mentioned food allergy, and a lot of people mentioned food sensitivities. There's an underlying assumption of many people in society that kids are behaviorally sensitive to specific foods or food components, and that decreasing the exposure to those foods will improve symptoms. There's a lack of evidence of that, but it's very appealing. You know, it's a natural thing I can do for my kid. We can promote a healthy lifestyle, and they're all very difficult to achieve in real life. So here is a carrot who is being absolutely terrified that he's got some wheat and some sugar coming at him. Salt, they don't usually tend to eliminate, so salt is innocent, but he is in cahoots with wheat and sugar. So dietary interventions, the most common that I'll hear about is sugar restriction and dye. It's a common belief that sugar creates hyperactivity, either by a functional reactive hypoglycemia, which Dr. Cordell mentioned, or a hypersensitivity to the sugar somehow that causes hyperactivity. There was a meta-analysis published in JAMA in 1995 that said normal kids and kids with ADHD, sugar does not affect behavior. And that study continued, those kinds of studies continue to be repeated. The list I found in a review article of negative studies was probably 3 pages long. My take when people ask me about this is if you want to reduce the sugar in your kid's diet, go for it. They're probably obese anyway or at risk of being obese. So it's not harmful. Maybe it'll help, but it will help the other health for the child. And then in 1975, there was this diet called the Feingold Diet. The older folks in here, sorry, Don, have heard of the Feingold Diet. Anybody else ever heard of it? Yep. So the Feingold Diet is where all of this stuff about dyes and food additives came from. So Feingold noticed in people who were sensitive to salicylates, like the folks who can't take NSAIDs because of allergy and the nasal congestion, their behavior somehow improved, or their level of stress somehow improved when they removed salicylates. So this guy took out all natural sources of salicylates in addition to drug sources. Now that's a lot of foods actually have salicylates in them naturally. I think pears do, for example. But he also removed food dyes and artificial flavorings and preservatives. Later, the diet was proposed that you could have the natural salicylates, but you just couldn't have the artificial dyes and additives. So this is where the dyes came from. Overall, they're not shown to be effective. There are some small studies that show if you take subgroups where parents say, my kid is sensitive, and remove those things that the parents report sensitivity to, that there's an improvement. So that's one caveat. But this is tough to do. You have to cook, which means you have to be able to. You have to have the resources. You have to know how to cook. But if you want to do it, it's not likely harmful, and nobody needs Doritos or red fruit punch. I don't think anybody really succeeds, but I do have a theory that the magnitude of placebo effect is directly proportional to how hard it is to implement the placebo. So if you try this hard, you're probably going to believe it works. So then there is this few foods diet that is the latest iteration of the Feingold diet. And there are some studies that I found that looked relatively okay, that say the few foods diet may have some effectiveness. However, it's nutritionally risky. They eliminate all additives, dyes, sugars, wheat, dairy, corn, yeast, soy, citrus, eggs, chocolate, and nuts. I don't know what you eat for breakfast. Typical diet to start out, 2 meats, 2 carbohydrates, which are rice and potato, fruits, a few veggies, water, salt, and pepper. And then once you achieve your behavioral improvement, you then start to add foods back one at a time to see if the child becomes sensitized. This is stigmatizing to kids. I remember the little girl came to my oldest daughter's birthday party, and I had proudly made the cake that she wanted. Well, it contained some food dye, not a ton. This family wasn't doing the Feingold diet, wasn't doing the few foods diet, but they had decided to eliminate all dyes. And what did they tell their kids? It causes cancer. So this little girl looked at my daughter and all of the other kids at the party, she was 8, and said, I can't eat this, it causes cancer. So that was my birthday cake. Now, as time goes on, my kids thought, well, she's being a bit of a brat, all right? So it is stigmatizing to the kids. They're different than their peers. So some dietary supplements with mixed evidence. Again, small studies. They're poorly or not controlled, and often have overly restrictive study groups, so they're very difficult to generalize. Are ferritin or iron, so look for mild iron deficiency and treat it even if they're not anemic. Zinc, magnesium supplementation, omega-3 fatty acids, and vitamin D. Omega-3 have enough studies out there that there's some meta-analysis available, and that really hasn't been shown to be effective. It's not harmful, but at least in meta-analysis it doesn't prove. Neither does vitamin D. Behavioral interventions are really focused on modifying the physical and social environment by reward and consequence for behaviors. This is something like parent training, like PCIT therapy. One of the ones that I really want to emphasize on here is I see a lot of self-esteem issues in kids with ADHD. So finding activities where they can likely be successful is really important. I've had a kid last week in my office. He was about maybe 9 or 10. How you doing? How's the school year going? I'm only seeing him every 6 months for his ADHD because he's been on stable medication for a long time and he's doing well. And he looked at me and he said, I'm fine, but I'm bad. And that just broke my heart. I'll hear I'm bad. I'll hear I'm dumb. I'll hear I'm disorganized. And they don't say it in a way of, I have trouble with organization, so these are the things that I do. They don't say it as a strength. This is a label that they have accepted onto themselves. So really paying attention to these kids' self-esteem is one of the things I focus on with parents. Some things that are aimed at improving self-regulation, cognitive behavioral therapy, which we'll speak a little bit more about, but this goes anywhere from yoga to organizational skills to green spaces, which is be out in nature, to recess, let the kids play for more than 10 minutes, let it be unstructured, let them be bored, let them figure out what to do with themselves as opposed to telling them what to do. And anyone who knows me a little bit knows why I have the picture of the horse doing yoga. Hippotherapy is one study that I found. I'm not going to bore you with it. It didn't show a big effect, and it was a strange sample group. Here is a liver chestnut or a really light bay, I'm not quite sure, doing some yoga. And I have horses. The cognitive behavioral therapy has really been studied more in adult groups, so 18 to 65. I do think it has definitely demonstrated positive effects. I do think it's probably generalizable to our older teens, our more mature teens. The effect size of cognitive behavioral therapy is about half that typically seen in drug studies. So for people who have mild symptoms or as an additive to pharmacotherapy, I think it's got a real place. And it is something that I can do in my practice. I can't do CBT. I don't know how, I'm not trained, I don't have time. But there are people in the community who do. But it requires buy-in from the family. The big things are, in cognitive behavioral therapy, it aims to change your thoughts and your behaviors that reinforce the harmful effects of whatever your disorder is, be it depression, anxiety, ADHD, teach techniques to control the core symptoms of the condition, and then help coping with the emotions like anxiety and depression that may come out of having the condition. It's been shown to be helpful in placebo-controlled studies, but also studies where the inclusion group was on medication. So it's helpful CBT versus placebo and CBT plus medication versus medication alone. So here's the main topic of this talk. I really found that the sleep disorder studies and topics were fascinating with respect to ADHD. And I think you'll see why, but I think this is something that as pediatricians we can integrate into our practice. Maybe not the way the research study that I'm going to discuss was done, but it's got some potential. So in children with ADHD, they have more behavioral sleep problems. They have sleep onset delay, so a little bit of sleep onset insomnia. They have bedtime resistance. So this is the kid who's getting up 15 times, or I don't want to go to bed. I don't want to be alone. There are monsters in my room. Something's under my bed. I need you, Mommy. Something I heard at my house a lot. Nighttime awakenings as well. They've got more sleep disorders, so restless leg syndrome, parasomnias, sleepwalking, sleep talking, bedwetting are parasomnias. Sleep disordered breathing is also reported in kids with ADHD, and we'll talk about that a little bit because I think it's more that sleep disordered breathing mimics ADHD than the other way around. And then there is research correlating executive function and sleep duration. So why do they have more sleep disorders? It's, not entirely worked out. There are shared neurobiological pathways that regulate arousal, so perhaps that's a mechanism. Stimulant medicine has been purported to cause insomnia, and one of the side effects that I list for families
There are comorbid mental health disorders. So remember I talked about comorbidities of anxiety, depression, ODD, conduct disorder. And most importantly, I think there are a lot of poor sleep practices. This is a kid that's already a little bit harder to parent. They're already a little bit hyperactive and impulsive. And so they're not the kid who's likely to lay in that bed compliantly until they fall asleep. So there was a Spanish study that I found really interesting. It was done in Pamplona. And they investigated the prevalence of sleep disorders and ADHD itself versus controls. They recruited from the school system. And so I think the groups were fairly well matched with SES status. They had 126 children with ADHD. Unfortunately, there were more inattentive in that group children than is typically seen percentage-wise, and more than 100 controls, more than 1,000 controls, sorry. And 82 of the study population was receiving medication during this study, which is, again, I think, fairly representative of the norm. What did they find? They actually found that medication wasn't necessarily responsible for the sleep disorders, and it may not exacerbate them. That was a little hard for me to think about, but their point was the sleep disorder is independent of medication. The rate of sleep disorder in the ADHD group with and without medication was the same in this study, amazingly so. It wasn't like the same within statistical significance. The percentages almost matched exactly. And the one difference they did find with medication was time reported to fall asleep was slightly longer with medication than without. But it was reported and not measured. And the reported difficulty falling asleep rate was the same. Sleep disordered breathing, we mean mostly OSA, obstructive sleep apnea. It can mimic ADHD daytime symptoms. However, in this Spanish study, only girls under age 12 were found to have a higher rate of OSA than the controls. So to me, this kind of says that OSA, while we want to believe if we take their tonsils out, taking their tonsils out, removing body parts, isn't likely to cure your ADHD. And I'm getting a lot of questions right now in my practice because there was pop media coverage of if your child sleeps with their mouth open, you need to talk to your doctor about going to an ENT and getting their tonsils out because this may cure their behavioral problems. Correlation did exist between sleep disordered breathing and shortened sleep duration and, in the kids who are more severe in their symptoms with ADHD. But medication severity wasn't less than the unmedicated group. So medication didn't seem to ameliorate it at all. So I love this picture of this little boy. Doesn't he just look like a kid with oppositional defiant disorder who's sitting in bed saying, I refuse to go to sleep? So what can we do about sleep? Everybody throws melatonin at these kids. And even if we as physicians and practitioners aren't throwing melatonin at these kids, the parents are. And big doses, like 12 milligrams, a lot of melatonin. So another Australian study, there was a randomized controlled semi-blinded study that was published in 2015. And in it were 220 approximately kids aged 5 to 12 with parent-reported moderate to severe sleep problems and ADHD recruited from 50 private practices in Victoria, Australia. They did a one-to-one randomization for sleep education intervention versus control. I like this study because it seems really real world to me. They had a unique recruitment method. They did an opt-out recruitment. So these 50 practices identified all of their kids with ADHD, and they all got a letter that says, this is IRB approved. You've been identified because your doctor says you have ADHD, and unless you return this postcard, we're going to contact you. And so they contacted all of these families. This is a huge job, and asked them to participate and screened them for inclusion and exclusion criteria. So I think they got a much more representative sample than relying on who's coming in and who's picking up the flyer, who's making the study contact themselves. They excluded relatively few children. Really, they only excluded low IQ and severe medical conditions or complex medical need kids. And by that I mean like cerebral palsy. They included kids with autism as long as they didn't have low IQ, and included kids with depression, included kids with anxiety. And pharmacotherapy was allowed per patient need. The physician was able to change meds. The physician was able to change doses in both groups. They did have to meet criteria by questionnaire for one of the following sleep disorders. So sleep onset association disorder, this is more bedtime resistance. Limit setting disorder, again, more bedtime resistance. Delayed sleep phase, so primary insomnia when you're falling asleep. Psychological insomnia, I'm not quite sure what that is, versus delayed sleep phase. Idiopathic insomnia or anxiety leading to insomnia. And then they were, I called them semi-blinded because some of the outcome criteria were parent report. Well, the parent had to participate in the sleep intervention, so obviously they were not blinded, but there was teacher report as well. Parents were asked not to share the study status with teachers. Probably happened to some rate, but that attempted some blinding. And then they had objective blinded outcomes as well, like an assessment of their working memory, so reverse digit spanning and actigraphy for sleep duration, so a monitor, like the Fitbit. What was their intervention? They did sleep consultations with the family, relatively few. And it was a psychologist and one trainee pediatrician or physician. They had zero formal training in sleep. So these weren't sleep fellows or sleep doctors. They learned over the course of 6 hours, these are the clinicians, about normal sleep, sleep cycles, sleep cues, sleep hygiene. So you guys remember sleep hygiene is no screens in your room, lights out, have wind down time, have predictable bedtimes, predictable bedtime routines, get exercise, all of those things that we talk about. Limit caffeine as someone drinks their coffee. All of those things that we talk about that are good for sleep. And they also learned about management strategies for behaviors that are known to be effective in typically developing kids. And remember, we did include kids with ADHD and autism in this study group. Okay. There. So what was their intervention? These newly trained sleep specialists went out and did 2 consultations and a phone interview with families. The 2 consultations were spaced 2 weeks apart, and then they had 1 follow-up phone call with families 2 weeks after the consultation. The first consultation, they assessed the child's sleep problems. They set some goals with the family. They did a sleep education related to that child's problems. And then they formulated a sleep management plan. So what might they be? If they're having trouble with limit setting and bedtime resistance, ignore their protests, reward positive behaviors of complying, good parenting. delayed sleep phase, where the kid is going to bed at midnight. You temporarily push their bedtime a little bit later than what they want, keep their wake-up time the same every morning, and then back that bedtime up slowly. Works for us, too, if we're having trouble with our sleep-wake cycles. And then kids who had anxiety, visual imagery, relaxation are examples of the sleep plans. The second consultation, they reviewed a sleep diary that they were to keep in between. They reinforced their strategies and were troubleshooting barriers. And then they gave some information sheets as well at that first consultation about normal sleep, common sleep problems, and about the sleep problems that that child was specifically having, and strategies for management. Found it kind of interesting, the time ranges that were spent in these consultations. The first consultation averaged an hour. I obviously can't do that. But there was a huge range of 15 to 86 minutes in that first consultation. The second was much shorter, mean of 30 minutes, and the phone call only had a mean of 13 minutes, with a range of 3 to 30. The kids did sleep better. So the rate of reported moderate to severe sleep problems at 3 months in the control group was 56%, the intervention group 30%. The number needed to treat of only 3.9, and this is all at a highly statistically significant p-value. And it persisted at 6 months. So they weren't getting any intervention after the first 6 weeks, and the effect persisted for 6 months. It dropped off some, as you would expect. This said to me, perhaps, if I talk about sleep early and often with my families, I can help them achieve some symptom control. Primary outcome was ADHD behaviors at 3 and 6 months reported by parent and teacher. The parent behaviors were highly statistically significant change at a level approximately half of what drugs do. And the teacher improvement, they showed reduced symptom severity at 3 months, didn't persist to 6, and it wasn't statistically significant, although it was close to statistical significance. For me, I think that this is probably higher at home because there was spillover of the behavioral strategies onto other areas of behavior for the parents. So the things that they learned to help get their kid in bed and keep their kid in bed also were effective with other behaviors. Additionally, teachers don't have to deal with the hassle of their kid not going to sleep and their kid getting up in the middle of the night. So I'm sure that that colored the response to these behavioral assessment tools. Other outcomes, they measured school attendance and tardies in the kids. That didn't change, but the parents missed less work and were late for work less often. So there were some things happening positive in the household. They measured parent mental health. The parents didn't feel any better afterwards, unfortunately. But the kids reported improved sleep. And so coming back to my kitchen sink of seemingly unrelated stuff. There's a lot of alternatives to medication and little to modest little to modest current evidence for effectiveness. I had to throw in one cultural reference. And I'm going to do a shout out to Ryan Fulton if he's still listening. In Botox, he told me I couldn't play this skit. Does anybody know what this is? Saturday Night Live. Who is it? And what's she doing? She's doing a spoof on Laura Ingraham from Fox News Channel. And this is the weekend of Thanksgiving, where she did this spoof. And one of the things that she said, our feel facts. They're not technically facts, but they just feel true, so they must be. So some feel facts about ADHD. Diet interventions don't work. Many years, many attempts, doesn't make a difference. Polyunsaturated fatty acid supplementation, well, that cures everything right now, and if it isn't cured by that, coconut oil really helps it. It's not currently supported by evidence. Parent training and behavioral responses doesn't show evidence in large studies. I think it's absolutely helpful, but that's my opinion. And I'm sure that Tara Mitchell and Laurie can find some papers that show it is.
Tara probably could.
Tara could, okay. Cognitive behavioral therapy is effective. If you're 18 and older in meta-analysis, we could probably generalize that down a little bit in age group for some teens. Sleep disturbance is really common, and it's not necessarily all caused by drugs. And if we can intervene in sleep disturbance, we can improve the core symptoms of ADHD. So some questions to see if everybody was paying attention. Which of the following dietary interventions are supported by evidence? Sugar restriction, artificial dye, artificial flavor and preservative, or none of the above? None of the above. Which of the following yes, that was supposed to be left. Which of the following complementary interventions for ADHD is supported by evidence? Cognitive behavioral therapy, supplementation with polyunsaturated long-chain fatty acids, or hypnotherapy. CBT. The only sleep interventions which can really help for ADHD symptoms are sleep medicines like clonidine, guanfacine, Remeron, trazodone, melatonin, or treating OSA. True or false? False. And then I have a lot of references. Any questions?
Do we have any questions in the room?
None? Nobody? I could not have possibly done that good a job. Dr. Jajo.
Dr. Jajo? Okay.
Not really questions, it's more comments.
Yeah.
I get a handful of kids every year for food allergies for this. I think it's mostly just pediatricians who are just fine, just go check it out. And to be honest, from my perspective, what I typically will tell them is the history is not consistent with an IgE-mediated food allergy, anaphylaxis, that kind of thing. Yeah. But a lot of these kids do come in with significantly restricted diets, and I hate testing for lots of foods. But these are kids that I will test for a lot of foods, more to prove to the parent that it's not a food allergy. Mm-hmm. And the other comment that I have is it always frustrated me as a parent when there were kids in my kids' classrooms who obviously had some problems with behavior and probably a number of them who had ADHD, and they were punished by removing recess.
Yes. Now, some of the food sensitivity literature and studies talk about IgG-mediated responses. Do you want to talk about that? I think you do.
Do you want to see my Groupon feed? You can order it on Groupon. It gets 4.5 stars. IgG is not allergic. Everyone will have positive tests.
Okay, thank you. Any other questions?
Any questions?
Comments?
We got a couple minutes. Okay, we're going to unmute the phone, so if you don't want to make a comment, please keep your phone muted so we don't hear your private conversations. All right, here we go.
The conference is now in talk mode.
Does anyone have any questions or comments?
I do. This is Dr. Ackerman, and Amy, that was a great talk. I just wanted to say I thoroughly enjoyed it. I think that a lot of folks clearly are walking around, impaired by the lay press and the Today Show and Good Morning America and all of that. how do you, so what is your advice to, other practitioners that are dealing with families just coming in with these wild and crazy ideas of what they should do? How do you deal with that?
So usually what I do is assess what they're doing a little bit. Ask questions of, tell me what you're doing, why you're doing it. And then, honestly, Alice, if it's not harmful or risky to the child, I don't always tell them to stop. Because I'm their primary care provider. I need a relationship of trust over the long term, and I've got time to make this intervention. I don't have to do it all at once. But I assess for risks, and I assess for risks like social risks, like that little kid who told my daughter that her birthday cake caused cancer. And so I talk about that. I talk about the fact that this isn't shown to be helpful. And things that are shown to be harmful that I know of, I tell them. And if I don't know what their intervention is or does, I don't claim to. I just say, I've never heard of this. Can you give me what you have found? Because I like to learn. Usually I don't get anything, but sometimes I'll get the printout. And then I'll go through that printout with that parent, and I'll say, this is how I look at it. This is what I see when I read this. Because often they're all testimonial or anecdotal evidence. So I don't have a great solution. I do try to steer away from that functional neurologist because I'm just offended that he calls himself a neurologist. And I point out very strongly that I talk about what neurology training is and how this guy doesn't have it.
Yeah.
I hope he's not listening.
Well.
Amy? Yeah, this is Michael Hart. Can you hear me okay?
Yeah.
Yeah, I just want to kind of follow up with Dr. Jadrow's comments because I see this a lot, as you guys can imagine. When you see the IgE food allergies is just the tip of the iceberg. The non-IgE or the putative food allergies, intolerances, all those kinds of things, we're bombarded with it. I'm sure the general pediatricians see 10 times as many patients as I do. I think one role we can play, reassurance is oftentimes not enough because of the parent's perception is reality. And as you aptly pointed out, even the involvement of the placebo effect, if you're really buying into it, that in of itself creates its own outcome. But I think one of the things we can do is help them think about scientific challenges and trials that I discussed with them the concept of blinding somebody, mother, father, therapist, whatever. Way back when, it may have happened too long ago for you guys to remember, but Dateline did a thing about secretin curing autism, and so I was barraged with all these kids probably 15 years ago, autistic kids begging for secretin. And of course I did it, but what I did was I kind of created a model where they had to be assessed. We got a therapist involved, a neurologist, we had independent observers, teachers, et cetera. And in the 6 kids I did, they all turned out to be false. I felt like I told the parents Santa Claus didn't exist. But the reality was, I think if we buy into this, coaching them as to how to do crossover studies, how to do eliminations, how to do challenges, I think that can debunk a lot of this stuff. The kids usually end up on far more foods than after they've seen me than before they came in to see me. And I think we play a strong role there.
And just like I have been the desperate pediatrician who refers to Laura when I'm at my wit's end, I sometimes will refer to you guys when I just can't move this family and what I think is being done is harmful to the kid, or the family just really needs to move on from their obsession.
I agree.
So thank you.
All right, looks like we're out of time. Thank you all for listening.